Imagine you have a new pair of shoes. As you walk, you notice your shoe is rubbing. You take them off and you see a small blister. You put a band-aid on it and 2 days later the wound is gone. Now imagine you have diabetes. You don't notice your shoe is rubbing because you've lost some of the sensation in your foot. The blister becomes an ulcer. Eventually your doctor notices and begins treatment, but your wound healing is impaired. Despite the best care, the wound becomes infected. Then the infection gets into the underlying bone, and eventually the only treatment option is the amputation of your foot. It's hard to imagine that a small blister could lead to a foot amputation. But for a diabetic person who gets an ulcer, 1 in 6 will require an amputation. This is enormous because 1.8 million Australians have diabetes, and this number is growing. For many people, they don't even know that they're diabetic because early on there are no signs. It's during these undiagnosed years that the high levels of sugar in the blood are doing the damage to the nerves and the arteries that lead to these chronic, non-healing wounds. Managing these wounds is challenging. We have national guidelines for their treatment, but for many ulcers, these wounds aren't being managed by these methods. We need new methods, and we have one. It's called low-level laser therapy. It's as simple as holding a small, light-emitting diode close to the wound for 90 seconds a day. This light stimulates the cells that help us heal. And studies have already shown us that laser therapy helps the healing of diabetic patients. So we have this piece of information out there. We have this tool that's non-invasive. It's portable, so it can be used in remote settings. And it doesn't require medical expertise for use. But we aren't using it. Our study is titled The Effect of Low-Level Laser Therapy on the Wound Healing of Chronic Diabetic Foot Ulcers in Type 2 Diabetes Patients. We're conducting a trial that will provide the high-level evidence needed to bring laser therapy into national treatment guidelines. We're doing this by using a randomised, double-blinded, placebo-controlled clinical trial with 140 patients. This means we'll have 2 groups. Both will receive exactly the same wound care as well as laser therapy, but only one group will be receiving a therapy level of laser. This will let us measure the success of the laser therapy. If successful, our results will let us push for this treatment to be put into national guidelines, having a direct impact on the 1.8 million diabetic patients who may have to manage an ulcer. If we can halt progression early, we can keep people from the life-changing burden of amputation. Thank you.